Hi, this is Saqib Rehman from the OrthoClips podcast, and today I'm with Dr. Ronald Navarro, and we're going to be talking about how is ethnicity associated with outcomes in orthopedic surgery. And Dr. Navarro is the Regional Coordinating Chief of Orthopedic Surgery of the Southern California Permanente Group of Kaiser Permanente. So thanks, Dr. Navarro, for taking the time to speak with me.
Oh, thank you for asking me.
Excellent. And I know you've done a lot of work on this topic. Again, the question is, how is ethnicity associated with outcomes in orthopedic surgery and the procedures we do? So before we get into the main topic, maybe you could just tell me how you got interested in this subject.
Yeah, sure. I'm Hispanic, and there aren't many Hispanics in orthopedics. I've done a lot of, or a fair amount of research in my life, and I really didn't want to make it about race or ethnicity. But in my system in Kaiser Permanente, where the care should be available to all, I had heard about other work with regard to disparities, and I wanted to see if my system, which fundamentally should be treating disparities equally, I wanted to see if there still was differential care, or if what we believe where access to care should be easier, if that was in fact playing out, and if outcomes were similar.
Okay. Yeah, I mean, I know now I'm a trauma surgeon, but I know we've looked at this in some aspects in our field, and I definitely know in elective arthroplasty, going back for some time, this has been a topic that's been investigated. What are the associations that you've found in your studies, or perhaps related studies by others, and how do they differ amongst procedural types? Meaning, are there certain associations with shoulder arthroplasty or hip and knee, or in trauma, and how do they differ?
Sure. There have been multiple studies that we've worked on. Our first study was in osteoporosis, looking at differential care. Then we did two papers over a period of time looking at ACL reconstruction, and was there some influence of race on both the preoperative characteristics and on outcomes. We've looked at race with regard to hip fractures, race with regard to primary shoulder arthroplasty, as well as race with primary total hip arthroplasty and total knee arthroplasty. So those are the 7 papers, and I can get you the references at another time. But interestingly, if we had to say something general about all of them, the results of the multiple studies suggest that depending on the type of operation, most times non-weight races, interestingly, have better outcomes of the ones we specifically measured, the outcomes we specifically measured, than the groups that were broken down into the white category. At times, the rates of emergency department visits and readmissions were notably higher in African Americans. We did look at multiple operation types from young to old differentially in these subpopulations, as you can imagine, ACL being a typically younger population than the arthroplasty and the hip fracture populations. So it's hard to make one overall statement. I do want to say, though, that we did break down in all of these studies our subgroups of ethnicity in Hispanics, because technically speaking, that's ethnicity. So many times we said race/ethnicity. And then the 3 races were white, black, and Asian. And we know that this is some sort of, to some degree, an artificial designation, because you would probably agree that there's heterogeneity in that African descendants who come from Spanish-speaking areas, or Croatians that fit into a white category, or Pacific Islanders possibly in Asian versus another category. So we did this to keep the subpopulations large, and statistics, you need to do it in a way so that you can gain some degree of conclusions. If you start substratifying to the degree where we would say it might make more sense with some of the subpopulations I described that I did not characterize, we might not find these conclusions. So I do want to say that you asked me about findings, I told you, but I also wanted to say that there's probably more work to be done in an even more stratified basis.
So, and you've, if I understand correctly, have used in your methods, you talk about using your the registry and database that you have in your health system. How, I guess, what have been the pluses and minuses of that, and how generalizable are your findings to other health systems across the country?
Well, what I think this can tell us is, obviously all of us, you're a trauma surgeon, as you say. So the very first thing we go to if we're trying to risk stratify and get involved in risk calculation with regard to operations and trauma, in your case, you largely have to do the operations. But if you can mitigate bad outcomes by modifiable factors, that's great. Race is not a modifiable factor, but I believe that what is generalizable is that when we start seeing these trends, that there's maybe more readmissions in some of the race population subcategories. Can we know this and try and work to mitigate that? We have a lot more work to do. I already have explained and mentioned the idea of getting more granular with different races. And we also are going to take the time now, and we're involved in a couple of studies at looking at the reasons why people were coming back to the ED, or the reasons why some people choose to have a reoperation and others don't. In some cases, you have to have the reoperation, a failed total knee that's unstable. But an ACL that tears again, an ACL reconstruction that tears again, if the individual or the people in a certain subcategory choose not to get a revision reconstruction, maybe they're just coping with it, and is there something that we can learn about that? So we have to go much more deeper on the race categories and much more deeper on the reasons why, but I think it can start giving people an indication, surgeons an indication in a generalizable way at what they might predictably see from some subcategories.
I see. And I would imagine that, healthcare systems being, certainly financially motivated now, to make sure that readmissions aren't happening, as well as, intrinsic motivation just to improve patient care. But I would imagine healthcare systems should have quite an interest in doing whatever possible to better understand why patients are coming back to the ER and getting admitted. And I would imagine there's interest in digging deeper into this topic.
No, you're absolutely right. The idea that in my system, I give other talks on my system, and I say I and many in my system are all cost centers. We're not profit centers. So the more streamlined and standardized we can get the episode of care where there's minimal return to care into an urgent care setting or an emergency room setting, or a readmission at 30, 60, 90 days, that is better for the patient, clearly, and it's better for our system because the system is trying to provide care for more patients. And if there is, just frankly speaking, more money spent on readmissions, that's potentially less care that can go to a primary episode of care that didn't have a readmission, if you understand what I'm saying. I think that's the direction you were going in.
Mm-hmm. Yeah, exactly. I mean, beyond the implications of understanding and hopefully minimizing emergency visits and readmissions, other important implications of your findings for our patients and health systems? Clearly,
the care that we'll all be involved in the future will be directed and take into account individual characteristics. Is race a proxy for a genetic implications of the way a outcome behaves based on the genetics of the individual? We cannot say with any definitive we can't say definitively that that's the case, but we are starting to think in that direction, and we are interested at the point where we have a bank of genetic markers, and we'll see if the behaviors we see from race are similar via the genetic markers. I will say that there's a population of folks that believe that this is probably not the way to go. I just want to be fair to their opinions, and there are some editorials that have called race-based studies into question. There was one in JAMA in 2018, Race and Ancestry in the Reporting in Medical Journals, as well as one in Clinical Orthopaedics and Related Research in 2018, editorial on the complexity of reporting race and ethnicity in orthopedic research. So others say that the generalization I may have made that race may be a proxy for genetics, they are questioning that. And so I'm just trying to continue to go forward and eventually make that correlation when internally we have some of our genetic information on enough patients to see if there is a positive correlation between these results. So I think there's just a lot more to do and a lot more questions than there are answers.
Yeah, that's it's a very interesting and balanced assessment. And I have to say, the sort of personalization of medicine and what's probably coming is really fascinating to me. The thought that instead of just giving one dose of a medication to everybody, that you understand how they're going to respond to that medication, and one person might right off the bat start with a different dose than somebody else because you know what they're more susceptible to or not. And it's, with the sort of standardization of medicine and protocol-driven medicine, it's going to be very interesting for me to see how we reconcile that with personalized medicine. On one hand, you're trying to sort of, to some extent, do the same thing to minimize errors, but on the other hand, you're doing things different because it's personalized. And I can't imagine how, to some extent, these investigations won't play a role, but that's just my opinion. I imagine the conclusion you're making is probably correct.
Yeah, I do want to make a small point, too, that we're unable to understand the behavioral characteristics of people. So if a patient is a breadwinner, he or she may be less apt to choose more care after an initial operation due to economic realities. If a patient has a higher copay than one who chooses a revision operation or emergent care, that may influence care patterns. So all those other issues have ramifications on our work as well. So I'm just trying to be fair to all the potential covariates, if you will.
Yeah, I think it's a tough topic to really control carefully and easily come to conclusions. So I guess, my final question would be, other than your suggestion that we should get a little more granular, especially with ethnicity, what other future investigations, especially to maybe some of the residents out there listening, could they consider doing to better understand this issue and improve patient care as a result?
I think beyond the granularity of different ethnicities, we need to start understanding why there were returns to care. And if there's an overarching reason, if it's pain in one race category and it's nausea in another, that's the part that you can maybe start saying, well, I have to think about this, in this category, and I have to think about that in the other category. There are all these buzzwords, ERAS, multimodal pain control. And so those can be targeted too if we know that overarchingly subcategories of patients return to care based on certain specific reasons, and then we can mitigate those reasons differentially, more to your, targeted and pinpointing care, even care that would mitigate a return to care. Mm-hmm. Does that make sense?
Mm-hmm. Yeah, I think that's a good point. I think it's an interesting topic, and I think we can keep talking about it, but I think for the sake of the length of the podcast, I'd like to bring it to a conclusion. Again, this was our podcast on how is ethnicity associated with outcomes in orthopedic surgery, and I've been with Dr. Ronald Navarro from the Kaiser Permanente Group in California. I want to thank you again for speaking with me.
Dr. Rehman, thank you again for asking me. This was great, and I will be interested to see if you get any responses to your podcast, and I'll certainly listen to it too. Thanks again.
All right. Thanks.